Dr. Alex Crean of HCA Florida Memorial Hospital.
Morning, everybody. I just want to thank JAX USA and HCA Florida Memorial for allowing me to speak today. So our title today, Octogenarians and Beyond, we're focusing on patients in their 80s and above with a problem that we all know about, colorectal cancer. But in my opinion, it's a patient population that sometimes doesn't get the care they deserve because of limitations and previous technology. But using technology that Dr. Abbas just alluded to, and then some process improvement ways that we take care of surgical patients, we're really able to take care of an important patient population. So here's kind of the issue at hand. Average colorectal cancer is diagnosed in the mid-60s, a little bit older in women. What's really gotten a lot of attention in the US recently, and should, is that there's a shift in younger patients with colorectal cancer. So you can see that's, over the past few years, that's really moved the needle there, triggering screening guidelines to move earlier. So everyone knows, the average age for screening was supposed to be 50, unless you had a family history or symptoms or something like that, but that shifted to 45. Really all societies agree on that, which is a huge deal in terms of healthcare costs, getting more people screened. And the reason we did that is because, unfortunately, in the US, we're seeing people in their 20s and 30s and 40s before you would ever think about screening them with colorectal cancer. So that's being addressed, and we're still trying to figure out why is that happening. On the flip side, we do recommend that we stop screening at around age 75. And that, that's based on a lot of recommendations. You have to look at the cost of doing that across the entire population, and what's the risk benefit? How long is someone going to live after that? We know after 75, it's really a discussion between you and your doctor. Do you want to screen? Because if we find something, what do you want to do about it? What kind of shape are you in? The treatment for colorectal cancer traditionally can be rough with a combination of chemotherapy, radiation, and traditional open surgery, large incisions, kind of similar to talking about cardiac surgery and then these new valve replacements. The problem is, we're living longer. Over the past 70 years, life expectancy has gone up by 10 years, excluding the past couple of years of the pandemic. That's probably going to continue to grow. So, we're stopping screening, routine screening at 75. The average person is living to 78, which means there's a lot of people living past that. So they're living past where they would get screened, but they're still going to develop these things. Cancer really, excluding certain risk factors and genetic traits, is the breakdown of the system and taking care of itself. So over time, something's going to happen. You will develop a lung cancer, a colon cancer. They're not necessarily hyper-aggressive, but as processes break down in your GI tract, your colon, your rectum, the large intestine, these things do develop. So the problem here is, we have this whole generation of patients that really helped build the country and made it what it is today. So, right around the time of World War II, and then just after that, in the early baby boomer population, so people in their 80s and 90s that are now saying maybe they had a colonoscopy 10 years ago, but they had some bleeding, or they had labs checked and they're anemic, or all of a sudden they're short of breath or tired. Then when we figure out what do we do about these patients, because they're older, but because of a lot of the technology that's being presented here today, the treatment of COPD, the treatment of heart disease, taking care of people in a rehab situation, they're living longer, but also with a high quality of life. And that's something that I always look at with my patients as well. We're not just about quantity of life, but quality of life. But you have people living into their 80s and 90s that are living independently, or living with their spouse. They're able to visit grandkids or great-grandkids, and we want to give them the full treatment. We don't want to tell them, you might just be too old to get treated. So with their permission, what I'm going to do is just share a couple of quick patient experiences that I've had that I've been fortunate to interact with, just to kind of highlight what we're able to do with technology and then process improvement. So this is Rex. He was actually 90 when I met him. Similar story. Hadn't had a colonoscopy in a long time because it wasn't recommended. He developed some bleeding and anemia, got some lab work checked, and then was found to have what's a rectal cancer. So that's really the end of the GI tract. It's very low down there. It was actually in an advanced stage. Long discussion with Rex and his family, obviously. Otherwise in very good health, heart-wise, lung-wise, in great shape. He actually underwent chemotherapy and radiation first to kind of shrink the cancer down, and then we had to make a big decision because Rex surgically would have to have basically the biggest operation that I know how to do, which is where you remove the entire rectum and a portion of the colon and then give someone a permanent colostomy. Not a conversation you want to have, but in a 90-year-old, major decision, talking about the risks and benefits, but if we're able to treat this, Rex can live for a long time. So that's him. I saw him, this was last year. I just saw him about a month ago to check in. He's 91 now. Fortunately, we were able to treat his surgery robotically, and he did very well. So why are we able to do this? Why is robotic surgery better than traditional surgery? As we talked about with cardiac surgery, giving someone a big incision, it creates a lot of issues. It creates a lot more postoperative pain. It's harder to breathe. It's harder to walk around. It's all things that we found out people do better after surgery the faster they're able to do it. The intestines take a longer time to wake up, which is called an ileus. So when we're able to do things robotically, which is really through small incisions in a minimally invasive fashion, especially in this patient population, it does a tremendous amount of difference for them. And that's what these journal articles highlight. So these are several retrospective studies in Italy and Korea over the past few years where they compared people in their 80s and 90s getting robotic surgery versus even traditional laparoscopic surgery versus open surgery. And not surprisingly, they do better. They have lower complication rates, they have lower lengths of stay, their mortality is certainly lower, and we're still having good outcomes in terms of treating the cancer. It's not just robotic surgery, though. So what Dr. Abbas was alluding to, all these technologies, we have them in our armamentarium, but we also have to look at the way we take care of surgical patients. And I think this is the key thing, where we're really combining the technology in the operating room with how we take care of people. Enhanced surgical recovery is a huge buzzword right now. I'm sure everyone's doing it at their hospitals. HCA is really big. We push it across to every surgery that gets done at the hospital. And what that means, a lot of it seems like common sense now, but it's the way we optimize patients. So we get them ready before surgery, make sure they're hydrated, make sure they're not malnourished. In the hospital, we're really trying to get these patients moving. So we're getting them out of bed, we're feeding them early, we're trying to minimize narcotics because we know especially older folks have adverse effects from that. And then at home, too, kind of similar to the our Mayo colleague here, we're not just sending them home and then kind of saying that's it. We're kind of constantly checking on them, making sure they're staying hydrated at home, giving them further patient education. When you combine those two, you can take care of these complex diseases in patient populations that sometimes may have honestly gotten turned down or just kind of told, what, you're 80, you're 90, maybe just kind of go home and hang out with your family. So that's really what it's allowed us to do. And there's no doubt it's a team approach. It's not just the surgeon, it's not just the oncologist, it's not just the radiation doctor. It's everyone together. It's the nurses on the floor, it's the nurses at home, and then everyone getting these people ready before surgery as well. So just to kind of share a couple of other stories. So on the left side there, that's Mr. S. He's 93 actually. So he had a right-sided colon cancer that was removed robotically. Family kind of bragged that really didn't blink an eye there. And then on the other side, that's Rex. So that's his colostomy. You can see really the incisions have healed very well, and we were able to minimize that rather than making a large incision down the midline, which is not the wrong thing to do. But in these patients, that could really affect how you have patient outcomes and how they do afterwards. We were able to get these done robotically, and they did pretty well. Just to kind of close here, again, this is not the newest technology in the world. Robotic surgery has been around since about the 1990s. It started with prostate surgery. That was the first people to really pioneer with urology. Then it moved on to OB-GYNs. They started taking out uteruses with hysterectomies there, revolutionized both fields. Colon surgery has been kind of the later player in the game. First robotic colon surgery was done in 2002, but it's really picked up steam over the last 5 to 10 years. And that's for all comers. So that's your average patient in their 60s. What's coming over the last few years, as you can see in those studies from Italy and Korea, is that we're able to apply it to higher risk patients. So super morbidly obese patients like Dr. Abbas, older patients, people with a lot of medical comorbidities, people that have had transplants. And that's, if you do that with a team approach and you take care of patients in terms of a smart process, you can take care of things that are tough that may have gotten turned down in the future, in the past. So I just want to close. I have a little video here that I thought was neat. This is an 87-year-old gentleman that's coming up. He had a right-sided colon cancer, same kind of story. Had anemia, had some bleeding, got a colonoscopy, hadn't had one in a while because he's 87, not unreasonable. It's a tough situation. but he did great. He had a robotic right colectomy. And this is him. I'm actually just seeing him a few weeks post-operatively. Full disclosure, he's 87. He's accomplished a lot in his life. He was a little camera shy, so this did take a couple of takes. He does have his granddaughter who helped us out, kind of prompting him in the background a little bit. But are we able to play that video?
I'm 87 years old. I had robotic surgery, and I'm doing great. And 1 week later, I was cutting grass in my lawn.
All right. Thank you guys so much for your time.